Hi, good afternoon, everyone. My name is Dominic Akatiba. I'm with Ghana Medical Help. Thank you for joining us for this week's webinar on stroke in the young. We are resuming our community service agenda project as part of Ghana Medical Help's contribution to keeping us updated as practitioners, especially in rural environments. This afternoon, we are being led by the Department of Internal Medicine, Upper West Regional Hospital, Dr. Med Henrietta Olugu, and who is a senior house officer at the Upper West Regional Hospital, Department of Medicine, and Dr. Abednego Ato, the head of department and physician specialist at the Upper West Regional Hospital. Today, they will be taking us through this discussion on stroke in the young. Some few housekeeping rules. You'll notice that if you try to unmute yourself, you'll be unable to. This is to prevent people from inadvertently unmuting themselves and then getting a distraction to all of us during the presentation. However, the chat box is available. Kindly make use of it. If you have a question, a comment, or any issue that you want to raise up whilst the presentation is ongoing, kindly put it in the chat box. We as hosts will be able to read that and be able to implement the change that you want to. However, at the end of her presentation, which we are hoping will last about 45 minutes, we'll have about 15 minutes of questions, of comments, of suggestions, of additional contributions, which will help to make this a rich webinar towards updating all of us. Without much ado, I welcome the team. I'll let Dr. Ato, our head of department, say a word, and then Dr. Henrietta would take us through the presentation. Thank you so much, and thanks for joining us for today. Dr. Ato, over to you.
Thank you very much, Dr. Katiba, and it's always a pleasure whenever I'm on this platform, Ghana Medical Help. Thank you for all the good work you're doing. So this topic was chosen because over the years and even globally, we realized that increasingly we're having a lot of young adults coming with stroke. And the epidemiological transition has become quite alarming, where in the past you see that most strokes are recorded in people 60 years and above. The trend has changed. So we want to review what the current literature says about stroke in young adults, and maybe that can form the impetus for us to carry out our own local studies to find out what the incidence or prevalence is here. So that's the reason for this topic. So Dr. Henrietta will do that the honors and do the presentation. Then afterwards, we would take any questions that may arise. Thank you very much.
Thank you. Good afternoon, everyone. My name is Dr. Henrietta Olugu, and I'll be presenting on the topic stroke in the young. So this will be the outline of the presentation. We'll go through definition of stroke, classification, the epidemiology and burden of stroke in the young people, pathophysiology, etiological factors, clinical presentation, how to diagnose it, management, prevention, rehabilitation, and complications and prognosis of stroke in young adults. So when we say stroke in the young, what are we actually referring to? WHO defines stroke as a rapidly developing clinical episode of focal or global neurological dysfunction which lasts more than 24 hours and may lead to death with no other cause other than vascular origin. According to the American Heart Association, they include any infarction of central nervous system tissue that includes the brain, spinal cord, and the retina, regardless of the duration of symptoms, and also incorporate silent infarcts that may be detected on imaging. So several literature defines young adults by different age groups, ranging from 18 to 45 to 15 to 55. But for this presentation, we're going to use the extended group, that's 18 to 50 years. Now, how do we classify stroke? It's in two main broad groups, ischemic and hemorrhagic stroke. Ischemic stroke contains about 80% of all strokes, and it occurs through thrombotic, embolic, lacunar or cryptogenic routes of disease. So you can have thrombotic where the occlusion is in the plaque is formed inside the vessel that is causing the stroke, but with embolic, the clots originate from either the heart or other vessels outside the central nervous system and then travel to the brain to cause the occlusion. Lacuna, in fact, lacuna is when the small vessels inside the brain are occluded. And then cryptogenic is when we can't find any identifiable cause even after doing our whole diagnostic workup. Hemorrhagic stroke constitutes about 20% of all strokes, and it's in two main groups: intracerebral hemorrhage, where there's bleeding into the brain parenchyma, and then subarachnoid hemorrhage, where the bleeding occurs in the subarachnoid space. In the young adults, realize that arteriovenous malformations, aneurysms, and drug-induced are the most common causes of hemorrhagic stroke, more than hypertension. And hemorrhagic strokes also include hemorrhagic transformation that is also seen in ischemic strokes. Now, with strokes, we can have transient ischemic attacks and stroke mimics. So transient ischemic attacks, as the name denotes, is transient. So the patient will come with focal deficits, but it lasts less than 24 hours. And when you do a diffusion-weighted MRI scan, you will not see any impact. And the risk of stroke, a real stroke occurring after a TIA, is 10 to 15% within the next 90 days. And the score usually used to risk stratify how probable a patient who has had TIA can have a stroke within the next 90 days is the ABCD2 score. And this score is used to risk stratify and know that, okay, this patient's a higher risk, so needs more follow-up. Now, there are some syndromes that can present, where the patients can present with symptoms suggestive of a stroke, but it's just a mimic. So a patient can come with migraine, just migraine with aura, or thought palsy, where they go into this state of weakness or paralysis post an epileptic seizure. It can last for at most 36 hours, but usually resolves within 15 hours. And also hypoglycemia, which sometimes consider about 30% of all admissions. So especially, don't forget that this mimics, okay, so yes. Now with the TOOS classification, it's a form of classification that is used in classifying ischemic strokes. We have the large artery atherosclerosis, where the carotid arteries have a stenosis more than 50%. We also cardioembolic in atrial fibrillation, valvular diseases, intracardiac thrombosis, patent foramen ovale. Small vessel occlusion, which also occurs, lacuna, in fact, from lipohyalinosis, where the chronic hypertension now causes damage to the the intima of the small vessels inside the brain. So now the intima, the endothelial damage is now occurs frequently, and this is replaced with lipids and fibrous tissue, which is not elastic as the normal collagen that is in the blood vessels. Can also have other determined causes like dissection, vasculitis, thrombophilia, genetic. We'll go through all of this. But about 25 to 35% of young strokes are cryptogenic. That means we do not have a determined cause of the ischemic stroke. Now, there are other classifications for ischemic strokes, like ASCOD, SSS TOOS, modified TOOS, but because of time, we'll not go into them. Now, looking at the epidemiology and disease burden of stroke in young adults, about 10 to 15% of all strokes occur in adults less than 45 years, which is an alarming number. Worldwide, about 2 million young adults are affected with stroke, and this rise has increased to about 43% over the past 30 years. And stroke is the number 2 cause of disability adjusted life years lost in people of 15 to 49-year-old. So that's a really alarming number. And the graph also depicts this rise. In Ghana, a lot of studies have been done, and it's noted that the mean age at which we diagnose our stroke is usually between 55 to 65 years. It has been on the rise over the years and then kind of decreased in the last 5 years. A research done at the Komfo-Anokye Teaching Hospital noted that the rise in stroke admissions had gone up by 260%. and the national prevalence of stroke is now 7.9%, and realize that there's an earlier onset of stroke 10 years ahead of what was initially done. Usually, most developed countries, stroke was usually diagnosed around 75 years, but they've realized that now about 10 years ahead, like 65 years of age, stroke is being diagnosed. In Ghana, the mean stroke, as I said earlier, is 55 to 65 years, which is a decade younger than other high-income countries. And over the past years, we've noticed that stroke cases have doubled from about 10,000 to 23,000. And that's a 61% rise in just 5 years. And they realize that the age group that has the highest rates in rising in occurrence of the stroke is 35 to 59-year-old group, which is the young people. In sub-Saharan Africa, incidence rate of stroke has gone from 53 to 88%. All this is looking at in the young population. So these numbers are tailored to the young population. And realize that there's a study done, that's the SIREN study, done in both Nigeria and Ghana, realized that 24.3% of all the strokes that they had looked at in the adults occurred in adults less than 50 years. And in that study, hemorrhagic stroke was the dominant type of stroke, occupying about 52.5%. And for the case fatality, you can tell that it's also high, 41 to 43%. And this has increased to 69% currently at Korle Bu. Notice that also for the coastal zone, that's the regions in the southern part of Ghana, 77% of strokes, there's a 77% higher stroke rates than in the northern part of the country. And most of the reason, 5 to 10% of the stroke patients that were seen at Kumasi, we did not have, just had neuroimaging because of cost. So access to imaging is also a limiting factor. Looking at trends in the sex and others, we have women 15 to 44 years, that's the reproductive age. There's a high incidence in this group because of oral contraceptive use, pregnancy, and migraine with aura. Oral contraceptive use gives 2 to 6 times percent higher stroke risk. So the fact that you are on oral contraceptive pills means that you are 6 times higher than having a stroke compared to a woman who is not on oral contraceptive pills. And pregnancy in this state, as we all know, is a hypercoagulable state. So that also puts them at risk of having a stroke. Usually peripartum and in 6 weeks post-delivery, that's the perineum. Preeclampsia and eclampsia is also a major independent stroke risk factor in women. Now, globally, we've noticed that there's a 25 to 43% increase in stroke incidence. And it's driven by rising cases of obesity, hypertension, diabetes seen in younger population. But also, some studies see that because of improved neuroimaging and better health seeking behaviors, it may partly explain the apparent increase in the diagnosis and incidence of stroke. Looking at the risk factors and causes of stroke. First of all, I want us to note that there are traditional risk factors and unique risk factors. The traditional risk factors, which include hypertension, hypercholesterolemia, smoking, obesity, diabetes, all occur in both the elderly and the younger adults in cases of stroke. All these risk factors, these traditional risk factors, are present in both elderly group and young adults. But in the young adults, they have an additional unique risk factors that have been added to already the traditional risk factors. So a young adult can have hypertension and diabetes and also have another unique risk factor of illicit drug use or oral contraceptive pills. So we are going to go through all these risk factors, the unique risk factors. So looking at cardiac causes of cardiac and vascular causes of stroke in young adults, we found out that patent foramen ovale, it's found in about 25 to 30% of the general population. And it occurs because there's a paradoxical embolism occurring, because the right side of the heart is where the venous blood occurs. So blood clots forms in the right atrium, and because of the patent foramen ovale, the blood is shunted from the right atrium to the left atrium. So blood clots, which was in the venous system, moves to the arterial system, and it's now pumped out through the left side of the heart to the whole body. So this is it's through this mechanism that you end up having a blood clot, a venous clot now in arterial circulation. Several trials have been used to compare closure of the patent foramen ovale to antiplatelet use, and it was realized that closure of the patent foramen ovale was superior in patients less than 60 years than to antiplatelet use. To do all this, they do the soap bubble contrast to detect where the direction of flow of the blood. Is it a right to left shunt or left to right shunt? Usually it's right to left. That's how you have venous clots entering the arterial system. With atrial fibrillation, paroxysmal AFib and subclinical are increasingly detected with prolonged monitoring. So an insertable cardiac monitor can detect AF in 12%, 12.4% by a year. And for them, anticoagulation is mandatory, and we prefer the DOACs over warfarin. You also can consider doing some genetic paneling in patients who have only atrial fibrillation. For cervical artery dissection, it's common in young people because young people are the ones who usually will go for chiropractic manipulation and will sometimes have neck injuries. So with them, the arteries in the neck, because of the manipulation done, it can cause a sudden decrease in blood flow to the brain, which will end up causing a dissection and end up precipitating a stroke. For vasculitis, there are lots. Primary causes like PACNS, which is the primary angiitis of the CNS, and the reversible cerebral vasoconstriction syndrome. Moya. We can also have SLE, Behçet's, and Sjögren also causing vasculitis. All of these, they are constricting the blood vessels, reducing blood flow to the parts of the brain that they are affecting. Takayasu arthritis, large vessel inflammation, mainly seen in young women. There are a lot more which we can't go into all. For thrombophilia is one of the causes because they are in a hypercoagulable state. Because one, for example, the antiphospholipid syndrome, which is the most acquired thrombophilia, they are not able to break down the clots. So it's like clots are forming in all of them: factor V laden, protein C, protein S, antithrombin 3 deficiency, sickle cell disease. Because of the sickling, there's always, it's like the cells are now have an affinity to just clump together, all of them causing strokes. And sickle cell disease is very notorious because by the age of 20, most sickle cell disease patients might have had a form of stroke. Polycythemia vera is also under this group because of the clumping nature of the vessels, of the blood cells, sorry. Now, for genetic causes, we have the first one is CADASIL, and CADASIL is the cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. And it's a hereditary progressive disease. And the NOTCH3 gene is what is implicated in this. And it's usually occurs in patients 30 years to 50 years. So if you have a patient coming, you are searching all over, you can't really find. Sometimes it could be genetic. Fabry disease, also X-linked, and this it's an alpha galactosidase A deficiency, where their cells are just, as I said earlier, there's damage to the blood vessels, and they are not able to break down these cells, these clots. With MELAS, which is mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. This is a genetic disorder affecting the mitochondria, and usually they will present with muscle weakness and stroke-like episodes. So if you have a patient coming, is very weak, has episodes of like weakness, goes off, and all of that, you might think of MELAS. It's rare, but it can affect. And most these patients will always have lactic acidosis. So in this, of course, genetic testing is how you'll be able to find these diseases. Now, drugs and substances, cocaine, there are lots, but just a few: cocaine, amphetamines, meth, heroin, opioids, all are going to cause stroke. Cocaine causes vasospasms, and which will lead to arrhythmias, and it can cause both ischemic and hemorrhagic stroke. Amphetamines increase the blood pressure, so all what is going to do is cause intracerebral hemorrhage. Heroin, if it's injected, you end up having infective endocarditis, but they can also smoke it, and that's it's sending them that it's the smoking of heroin increases their risk of stroke by a very high percent. So most of them, within a few hours, they can easily just come in with a stroke. Alcohol causes acute hypertension and also coagulopathy, so it can increase the risk of them coming in with a hemorrhagic stroke. Energy drinks, and as I said earlier, oral contraceptive pills. Now, migraine and the cryptogenic types. For migraine with aura, it increases the risk of a patient coming with stroke by up to four times. And especially women who are already on oral contraceptive pills and they are also having migraine with auras, and then they are smoking, that's a 4 times, is the tetrad risk. So they are 4 times more likely, increases their risk of getting a stroke by about 30%. Cryptogenic stroke occurs 25 to 35% of young stroke will have a cryptogenic. Cryptogenic stroke, 25 to 35% of young stroke is seen because even after a full workup, we still do not know what is exactly causing that stroke. So, and we also have an embolic stroke of undetermined source, where we know that it's an ischemic stroke, but we can't tell where the embolus came from or the site of the thrombus. We can't really find where it's coming from. And for them, they would need active long-term monitoring, especially because of we do not know where the source is, and they are higher risk of getting another embolic stroke if it's not found. Infections can also cause strokes in young people. For bacterial causes, we have infective endocarditis, bacterial meningitis, neurosyphilis, TB, Lyme disease. All of these are implicated in stroke in young adults. Viral causes, chickenpox, usually after chickenpox post, and then they have stroke developing post the disease. COVID-19, retro, CMV, hepatitis C. Fungal causes like cryptococcal meningitis, aspergillosis, mucormycosis, parasitic causes, that's cerebral malaria, neurocysticercosis, and Chagas disease. So for the infections, their mechanism of diseases, a septic embolus forms from the infective site. And then this septic embolism can either just occlude or it would irritate the blood vessels for inflammation to occur. The intima is destroyed, healing will occur by fibrosis, and further occlusion causes. Also by hypercoagulable states, because the infection, as we know, sepsis causes puts the patient in a hypercoagulable state. Clots can form, and that can also lead to the stroke. They can also have direct vessel invasion, where the parasite or the microorganisms identified directly attack the blood vessels and occlude them, causing the stroke. Can also be a cardiac embolism. Now, looking at the pathophysiology, we have to understand the normal cerebral perfusion pressure. which is calculated by subtracting intracranial pressure from the mean arterial pressure. So the normal cerebral perfusion pressure the brain needs is 50 to 70 millimeters of mercury. So the brain is able to maintain normal cerebral blood flow across a map of 60 to 160 via myogenic reflex. This means that when the arterioles detect that the map has increased, they dilate. They dilate and the pressures now begin to decrease. If the map decreases less than to about getting to 60, then they sorry, I mixed it up. The arterioles will constrict when the map increases, and then they dilate when the map decreases. So this is an attempt to buffer the pressures in the brain. Now, if the map goes, that's the mean arterial pressure decreases below 60, hypoperfusion occurs, and that will lead to ischemia. If it continues further and further, ischemia will worsen. If the mean arterial pressure now goes above 160, edema occurs in the blood vessels, they rupture, and then hemorrhage occurs. So that's the main picture. So as I said earlier, once the cerebral perfusion pressures start dropping below 50, ischemia occurs, there's irreversible neuron death, and infarction now begins to set in. And once the perfusion pressures still keep decreasing, the penumbra is established, and when that occurs and still perfusion is not adequate, the infarction sets in, and now it's an irreversible infarct. So for all of the diseases, as I said earlier, thrombosis can occur in the first stage. So a thrombus will form or an embolus, which will block the cerebral artery, leading to cessation of blood flow to the territory. So, or the vessel itself will rupture. If it ruptures, blood is not getting to the cells. It's just on top of, it's like in the parenchyma. It's not directly entering into the neurons. Now, this will lead to ATP depletion. And we all know that the sodium-potassium ATPase pump needs ATP to function. So if oxygenated blood is not getting to these neurons, the pump cannot function. So you end up having more sodium entering in the intracellular space. And once we know that where salt is, water follows. So water inadvertently enters the intracellular space. There's swelling and irreversible cell death. And when this occurs, there's also massive increase in glutamate release. Glutamate is needed for the synaptic responses in the neurons. So, but it's supposed to be in moderation. Once this glutamate is is excess, there's overactivation of the NMDA receptors, which will cause calcium to enter the cells and then lead to neuron death. And once the cells now rupture because they've died, there's apoptosis has occurred, so they die. They release reactive oxygen species, which now overwhelm the neurons and further worsen the already ongoing ischemia or infarct that is occurring. And this leads to a necrosis in the ischemic core. And if reperfusion is not established as quick as possible, a penumbra occurs. So penumbra is just the region around the core of the infarct. It's just a region around the core of the infarct, which is at risk of infarct or ischemia, but it has not yet become an infarct. So it's salvageable if reperfusion is done in record time. If not, it also would, the ischemic core will enlarge and involve the penumbra. Then now you have a larger area of infarct that has formed. Looking at hemorrhagic stroke, as I said earlier, there are two main types: intracerebral hemorrhage and then subarachnoid hemorrhage. For ICH, there's rupture of the small penetrating arteries inside the brain parenchyma. And this hematoma now begins to expand because blood is still being pumped by the heart and it's reaching these vessels. And within the first 24 hours, there's hematoma expansion of about 40%. And with that, there's perihematomal edema occurring, because as I said earlier, water begins to enter the cells. So the cells surrounding the hematoma now begin to, there's perilesional edema. Let me just say it as that. And if this is not mitigated early, the hematoma will continue expanding, edema is occurring, it can end up leading to a mass effect, which will raise the ICP, the intracranial pressure, end up causing cerebral herniation if this effect is very large. For subarachnoid hemorrhage, the rupture is in the subarachnoid space. So because it's in the subarachnoid space, it leads to a sudden increase in the intracranial pressure. So the patients will come to you that this is the worst headache they've had in their life. It's like thunder clapping. And usually they can come with lots of consciousness. So if the this is not mitigated early, the blood can end up causing the hematoma can end up causing hydrocephalus, because it blocks, the blood is blocking the CSF, and which is acute, but also can become chronic when it's not treated early. The other mechanisms of brain injury include neuroinflammation, where all these cytokines are released and the blood-brain barrier is broken down, leading to edema. And reperfusion injury can also occur, where there's, because of return of blood flow to the area, free radicals that are in the blood now begin to damage the neurons, and then you end up having more damage post the infarct or that has occurred. And also you can have cortical spreading depolarization, where because of the ionic imbalances that is being generated from the infarct, you end up enlarging the core of the infarct. So it spreads, and to sometimes even include the penumbra. In a clinical presentation, there are the acronym FAST is what we use to identify stroke head on. So face, F for face, looking at unilateral facial drooping or asymmetry. They may complain of numbness at a part of their face. They can even come with dysphagia or difficulty swallowing. Their arms or limbs, they can come with weakness or numbness or inability to move that part of their body at all. Can also come with slurred speech or aphasia, inability to speak at all. As I said earlier, time is of the essence. So we need to identify when the symptoms started to know how to intervene and when to intervene. Now, additional symptoms, they can describe a sudden severe headache, as I said earlier, which is very cardinal for subarachnoid hemorrhages, but can also be seen in intracerebral hemorrhages. They can come with visual disturbances like homonymous hemianopia, where they tell you that they are not seeing part of their visual field is reduced. You can also have diplopia and amaurosis fugax, which is a retinal TIA. So they will come like they just felt like a dark blanket covering their eye, and then in a matter of minutes to hours, it resolves. So that is a warning sign that the patients can have a stroke in the future. Also can come with vertigo, nystagmus, ataxia, and altered state of consciousness, especially if the thalamus or brainstem is affected, or some part of the cerebral cortex. So there are anatomical stroke syndromes for the middle cerebral artery can have. So these arteries have been noted to affect a certain part of the brain, but that's where they supply blood to. And they now come with symptoms of the loss of brain function of that part of the brain. So because of time, I'm not going to go too much in the details, but you can look at it later. So for middle cerebral artery, the dominant hemisphere is the Broca's area, Wernicke, so they can come with aphasia. For the anterior cerebral artery, they can come with a frontal lobe syndrome. So apathy, and also come with urinary incontinence. For posterior cerebral artery, they can come with anopnia, where they can't, the macula is spared, but they can't really see past the peripheries. They can also come with loss of sensory loss and pain syndrome. For the posterior fossa or basilar arteries, they can come with some of the cranial nerve palsies, because of that's where they traverse. So all these arteries supply blood to certain parts of the brain. So if they come with certain symptoms, you can extrapolate that, oh, this is a part of the cerebral artery that was affected, and then you can tailor your management towards there. Now, for unique features in the young adults, some will present with neck stiffness or pain. As I said earlier, they can come with the cervical artery dissection. So if a patient comes neck pain, stiffness, aside from your suspicion of cerebral meningitis, you can also think of a stroke. Looking at their drug history, oral contraceptive use, and pregnancy, also because young people are not in the earlier years, we weren't really looking at stroke occurring in young people. Sometimes diagnosis is delayed because we attributed most of these symptoms to the elderly. But now, with our knowledge, we can, if you see this, you know that, okay, even though the person is young, you cannot rule out a stroke. In pregnancy alone increases your risk of stroke by 3 times compared to a non-pregnant woman. And it's highest, as I said earlier, in the peripartum period and the first 6 weeks postpartum. And they can also come with cerebral venous thrombosis, eclampsia, and a reversible reversible cerebral vasoconstriction syndrome. So with this RCVS, they'll come to you complaining of severe headaches, like thunderclap headaches, very severe. It comes for some few minutes and then it resolves. Then maybe a week or so, they might have it again. So when a patient comes with those complaints, please think of RCVS because it's notorious for that. But for this syndrome, it resolves in 3 months. So they don't have it occurring for the rest of their life. In 3 months, it usually resolves. And for pregnancy, we prefer using heparin because it has not crossed the placenta. Now, stroke mimics, they can come with hemiplegic migraine. So they will have an aura, but it's just a part of their body that they are not able to use. And it's usually there's a family history of a similar presentation. So you can find out the family history. For Tourette palsy, as I said earlier, it's a post-ictal state. So they will have focal weakness, usually resolves within 15 to 36 hours. And hypoglycemia, once a patient comes, aside from the vitals, always make sure you've checked their blood glucose level to make sure that it's not hypoglycemia that is giving the acute focal deficit. So we can also do all these other MRI to distinguish between a tumor or any other cause of the stroke mimics. Now, as I said, we usually don't sometimes look at the psychosocial impact of stroke, but it can impact, of course, their career, their finances, and their cognition. Now, for diagnosis, urgently, you have to know their full blood count, because in an infective state, of course, there will be leukocytosis. You also have to look at the clotting profile. You are looking at their glucose levels, their renal function, liver function. If the patient has a myocardial injury, you also can check the cardiac troponin. Sorry. Every woman that comes before you, always do a UPT or beta ECG because it's mandatory. Pregnancy in itself can cause a stroke. And toxicology screen is necessary in especially the young adults. So you can screen using their urine or serum if you suspect that an illicit drug was implicated. For the thrombophilia screen, antiphospholipid antibodies, you can look for that, looking for SLE, protein CNS, and anti-thrombin factor V Leiden. All these, there are specific tests for these thrombophilic anomalies, so you can search for them and test directly for these deficiencies. For cardiac investigations, an ECG is indicated. Any patients coming with a stroke, whether it's hemorrhagic or ischemic, you have to do an ECG and chest X-ray. If possible, can do an echo. For example, specifically the transthoracic echo that's on the chest, the one we normally use. That's going to assess all the valvular function, if there is any intracardiac thrombus or such as in infective endocarditis. If any of these are present, your transthoracic echo would tell you. You can also do a transesophageal echo. Usually, if there's a left atrial thrombus, where in that appendage, that's where the thrombus formation is very notorious for that part of the left atrium. So you look for using a transesophageal echo, you can pick up these anomalies and even patent foramen ovale. For all of these, cardiac monitoring is indicated. For the autoimmune and genetic disorders, you can do your ANA, that's looking in the complement levels, looking at SLE, ANCA, your P-ANCA, C-ANCA, looking at the vasculitis. For syphilis, if you're suspecting syphilis, VDRL is implicated. For sickle cell disease, of course, hemoglobin, HB electrophoresis, and these other genetic mutations, you look for the ones specific to these diseases. For neuroimaging, CT scan of the brain, non-contrast, is the first line. Investigation, because it will rule out hemorrhage and early ischemic changes which may be subtle. So there are a lot of scores that is indicated in stroke, but for our parts of the world, we don't really use all of them. When we get there, I would specify the ones we commonly use. For MRI of the brain, it's the gold standard, but of course, we know that in this part of the country, we do not have an MRI. So CT, a non-contrast CT scan, is what is used in diagnosing of a stroke. You can also do a CT or MRI angiography, where you can actually identify the particular vessel that is being occluded or that has ruptured. And also for CT or MR perfusion, you can see where the penumbra is and be able to know how much you can salvage. So this is an image, CT imaging is showing ischemic stroke and hemorrhagic stroke. So on the image here, you can see this hypodense region in the parietotemporal region of the right cerebral cortex, showing an ischemic stroke or an infarct. And then on your right, you see a hemorrhagic stroke, which has the hyperdense lesion spreading into the lateral ventricles, and this is an example of an intracerebral hemorrhage. And you can see that it's even causing some mass effects, because if you look at the midline, it has kind of shifted a little, a mild mass effect. So this is MRI imaging. For MRI, the interpretation of the imaging is based on whether, one, the type of stroke that has occurred, hemorrhagic or infarctive, the type of MRI sequence used, whether you are using FLAIR, T1, T2, yes, all these different, the diffusion weighted, all of them, the blood and infarct have different colors depending on the MRI sequence you use, and also depending on the type of the timing of the infarct. So if bleed. If it's an early bleed, it's a different color based on the type of sequencing. So this is some MRI imaging denoting stroke. For acute management, for every patient, time is of the essence. So of course, you're assessing the airway. You're also looking of supplemental oxygen, making sure that if the patient is desaturating, you are giving them oxygen to increase the saturations. Your main drive is to make sure that oxygenated blood is getting to the brain. So if oxygen is what you need, you give oxygen. If you have to you realize that, for example, in the breathing, the BPs are below 220, 120, you are not in a rush to bring down the BPs, especially in ischemic strokes, because that sharp decline in the BPs is going to now worsen your infarct score and involve your penumbra. For disability, if it's an ischemic stroke, you are going to use your NIH-SS score. That's going to help you quantify the deficit and guide the treatment decision. So if your NIH-SS score is less than 5, you are going to use. It's less than 5. You are going to you can do your double antiplatelet therapy if it's above 5. So depending on the score you get, the treatment varies. Of course, you have to do a full neurological exam for every patient, because we had a patient one time that came with cerebellar signs of cerebellar lesion. So she had this dynokinesia, also had pass pointing. So you have to do a full neurological exam. That will also give you an idea of which part of the brain is affected. And you have to know when the symptoms started. As I said earlier, for ischemic strokes, once you know the time that it started, within 4.5 hours, you can give you can give you can thrombolize. Yes, that's the word. You can thrombolize, you can give thrombolysis. So if a patient presents within the first 4.5 hours after the onset of symptoms and it's an infarctive stroke, we can actually thrombolize. We don't have to just wait and just do antiplatelets or anticoagulants. We can actually thrombolize. Yes, so the Altipace protocol is what I was mentioning. The time window is within 4 to 5 hours of 4.5 hours, sorry, on symptom onset. So the dose is 0.9 milligram per kilogram. You give it IV, and it's 10% is given as a bolus over 1 minute, and remainder is given as a 60-minute infusion. This has actually been successful in our facility, so it works. So we can do it. So if a patient presents early, you can refer to a higher facility where they can get the Altipace, and then it can be done for them. Absolute contraindications, okay, as seen if a patient comes with intracranial hemorrhage, you see on CT, you are not going to thrombolize. And if the BP is greater than 185 on 110, if you are going to thrombolize, you are increasing their risk of bleeding and hemorrhagic transformation. So for pregnancy, it's a relative contraindication. You look at the risk and the benefits. Can you do mechanical thrombectomy instead of doing a systemic thrombolysis? If that is possible, you can do it. Large tertiary infarcts, they show, those are infarcts that the aspect score, which is the Alberta Stroke Program LECT score. It's used to know the region of infarct that and how likely it is to occur, to have undergo a hemorrhagic transformation. So you are looking at, if this aspect score is less than 6, then it's not you are not too worried about hemorrhagic transformation. If a patient has had a recent major surgery or MI, thrombolysis is at the specialist level. They would discuss intervention. Of course, after thrombolysis, you have to monitor the patient. You are monitoring their vitals. You are monitoring their any signs of rebleeding. And if you realize that they are showing signs of intracranial bleeds or sudden headaches and post the thrombolysis, you have to stop the infusion you are giving. And if CT scan is available, you do an urgent CT consult scan to assess if a rebleeding has occurred. So these are very, very specific treatments. We are going to skip over them because of time. Now, for hemorrhagic strokes, if the patient was on any anticoagulation, you stop it immediately and you try to reverse it using some of these medications. Your target systolic blood pressure is less than 140. So you can use oral antihypertensives to try and bring the BP down. You are not in a rush to use the IVs unless the patient, one, is not able to swallow and you can't pass an NG tube to give oral medication, or oral medication is not available in your unit. But ideally, we prefer the oral medication because they are good in bringing down the BPs and maintaining the BPs at that level. The IVs crash the BPs and then the BPs go back up quickly. And of course, if you are you have a neurosurgeon in your vicinity, you can get a neurosurgery consult for decompressive craniotomy if you have a large bleed. For all these intracranial bleeds, the mainstay is trying to stop the bleeding. So anything that is going to precipitate more bleed, you try to stop it and mitigate that risk factor. For secondary prevention, now the patient has had the stroke and has come to you, are monitoring, you are giving them management for the rest of the year. You are going to put them on antiplatelet therapy for transient ischemic attacks. And you can give a loading dose of aspirin, 300 milligram, and then 75 milligram daily in the long term. For those who have qualified for dual antiplatelet therapy, they're giving aspirin and clopidogrel. Aspirin for 21 days, clopidogrel, they'll continue it for a longer period of time. Yes, so anticoagulation for a cardioembolic stroke that's seen in atrial fibrillation, they are going to be on lifelong anticoagulation. So we usually use what's common in our region, rivaroxaban, but you can also have dabigatran and apixaban. You can use all of them. They are more preferred over warfarin for atrial fibrillation. For the antiphospholipid syndrome, you put them on warfarin if their INR is between 2 to 3, because for them, a trial done noted that the rivaroxaban, the DOACs are not that good in controlling the anticoagulation therapy. If a patient has a patent foramen ovale, of course, you refer them to where they can get it closed and put them on dual antiplatelet therapy for about 6 months. Whichever cause you identify as the reason for the stroke, you try and treat that cause or manage that cause. Some of them, especially the genetic ones, there's no treatment. But if you can put them on steroids, depending on the type, you treat the cause of the stroke. Hypertension, dyslipidemia, so lifestyle modification, you put them on diet therapy, whatever is causing the dyslipidemia, so you can start on statins. Atorvastatin, usually we give 40 milligrams Nocte. That's what's usually do in our region. If a patient comes with hemorrhagic stroke, you are not going to be too in a rush to give statins because it's not recommended. The patient is already having a bleed and you do not want to cause a rebleed. For, as I said earlier, lifestyle modification in diabetes and obesity is important. If your sugars, your HbA1c is very high, your target is to try and bring it to a good control. Okay, so if your HbA1c is greater than 10, you have to start on insulin. You start with oral anti-diabetic agents. If a patient is smoking, you tell them to stop. Is drinking alcohol, doing illegal drugs, you also counsel them in stopping. For rehabilitation, physio, occupational therapy, speech and language therapy, and clinical psychology with mental health is very important, because it's a long process. They are not going to get back just right now. Their management is going to go over a year or longer. So this multidisciplinary team is very crucial to treatments. Now, complications of stroke. Early, as I said earlier, cerebral edema can occur. They can also have hemorrhagic transformation, and some of them can come with early seizures. And if a patient is already having dysphagia, aspiration pneumonia is a very, very common medical complication, because in their attempt to swallow, they can't swallow, so they aspirate the food content. They can also come in the long term with post-stroke seizures or epilepsy. And this is a higher risk when there's cortical involvement. They can also come with post-stroke neuralgia or pain, where they are having severe pain or this like neuropathic pain that nothing seems to work with them. They can also have, of course, cognitive impairment. If that's the cortical part of their brain was involved, they can have cortical impairment. Systemic complications, because of the risk that they might have had, DVT, PE, they are all complications of the stroke. Can have because they are immobile. So in them, we prefer the low molecular weight heparin for prophylaxis. If, of course, there's no hemorrhage, and cardiac complications also occur. You can also have pressure injuries, because if these patients are just at one place lying down, they're not being regularly turned in bed, they can have pressure ulcers. And UTI, because if patient is on catheter, you have catheter-related urinary tract infections. So as early as possible, you have to remove your catheter. You can also come with post-stroke depression and fatigue and some other complications. Now, there are some prognostic factors. You assess their NIHSS score. Yes, boss.
Let's try and wrap up.
Okay. So ICA score, which is the intracerebral hemorrhage score, is assessing the risk of mortality in the next 30 days. A score of 1 is 13, score of 2 is 26% risk, score of 3 means that the patient has a 72% risk, and the higher goes to 99. So these are different scores that is used in assessing stroke. NIHSS score is used in the ischemic and infarctive strokes. As I said earlier, ABCD2 is used to assess the risk of stroke in a patient who has come with TIA. We also have these other scores that we also use, but it's not really used in our aspect of the world. As I said earlier, ICH score, it denotes the risk of mortality in intracerebral hemorrhage in the next 30 days when a patient comes. So use all these factors to assess the risk and counsel the patients and their relative accordingly. So in summary, stroke in the young is rising globally, accounting for about 10 to 15% of all strokes. And the causes and risk factors is very diverse. So you have to use a thorough workup to look for the exact cause in that patient in front of you. The gold standard is MRI, but in a part of the world, CT scan, non-contrast CT is perfect. You can have thrombolysis is effective in ischemic strokes that present less than 4.5 hours from onset of symptoms. And long-term outcomes are better in the younger patients than in older patients. But because of the younger nature of our patients, they can end up having more psychological and cognitive impact than a patient who is elderly and would need a lot of support. Thank you. These are my references.
Excellent. Thank you so much, Dr. Henrietta. And I've learned a lot. I'm sure a lot of our participants have. And I see a lot of applause coming from lots of them in the chat box and throughout the reactions. So we've gone top of the hour. We'll take some 3 questions. If you have any, kindly put up your hand and then we'll mute you to talk. If you also want to use the chat box, just type in your question and then we can spend some 5 minutes answering those. So there's a first one in the chat box from James Addy. How do you prevent reperfusion injury when given supplemental oxygen in stroke management? So Dr. Ato, and if you want to help with that so that we can move in faster.
I thank you very much. Maybe I don't know why, but I can't seem to see the question. Is it just me?
Maybe
Why?
I'll just
Me too, I
enable.
can't see.
Oh,
Yeah.
okay. I actually enabled it just a while ago, but I don't know. Maybe it's the settings. I may have to relook at it. But
But
I
what?
just saw that. So the question is, how do you prevent reperfusion injury when giving supplemental oxygen in stroke management? So he's asking about like reperfusion injury post the infarction. How do we prevent that?
So
Then
I get
I think that's the only question actually in the chat box.
more
Yes.
with the infarctive strokes. So basically, with the infarctive strokes, the risk factors. That's what you have to take care of. Like she mentioned, acutely when the patient comes in, once they meet the time threshold, which is 4.5 hours from when they were last well or from the onset of symptoms, you are allowed to thrombolyze if you're in a facility that can do that. And the question you need to ask yourself is what are the causes or the risk factors? So if it's hypertension, if it's diabetes, you do that, and your of course your high dose statins and the likes, then you treat any other infections or comorbidities or watch out for any complications. With regards to the reperfusion, if the patient has not undergone any reperfusion strategy, then there's really nothing to do, because remember, in infarctive strokes you can you can do a reperfusion strategy, which is what we encourage when they come in early. That's a thrombolysis using the tissue plasminogen activators. But in our settings, because most of them do not come in very early, we are unable to do the reperfusion for them. So reperfusion injury really do not come in if you are not undergoing any reperfusion strategy. And the reperfusion strategy here is a thrombolysis, or sometimes you do the endarterectomies surgically if you have very large vessel atherosclerosis and all of that. And that one, there are very specific protocols that are in place for that. I don't know if that answers the question. Maybe whilst we are waiting for the other questions, I just want to throw a bit more light on a few of the things she said. So normally with a stroke in the young adults, the risk factors are basically the same for the stroke in the general population, except that with the young adults, they also tend to have other additional factors. And most young adults, especially 18 to 45, globally, have been shown to engage in a lot of smoking, and smoking, especially cocaine and the likes, have been shown. It's actually one of the most important causes of stroke in that age group because of the endothelial damage it can cause, the vasospasms and all the likes. And it's not even just for stroke, also for acute myocardial infarctions. Cocaine is one of the most notorious causes in young people. And unfortunately for women, in young adults, the women tend to have additional risk, and much of that has been attributed to the hormones. So, with all the hormones at that level, they tend to increase them and put them at a prothrombotic state, and that increases their risk for stroke. So if you're a woman, being a woman alone, you're at an increased risk. There's a tetra, the deadly tetra. So if you're a woman and you smoke and you use oral contraceptive pills, and you have migraine with aura, one person, you are putting yourself at a 30-fold increase of stroke. So those are the things that we want to be the takeaway message for today's presentation, and most especially the contraceptives as well. So at least if you tend to reduce your risk of illicit drug use, contraceptive use, and smoking use, it tends to reduce your risk significantly. The question, the point about the high dose statins, irrespective of the LDL levels, when it's an infarctive stroke, you have to give them high dose statins. And statins are not necessarily contraindicated in the hemorrhagic strokes. There's a lot of mixed results in that area, but more recent studies have not really shown it to cause any increased risk of intracranial bleed, except that the teaching is that you have to individualize it to the patient you are taking care of and assess their cardiovascular risk. But you can't use statins in hemorrhagic stroke, just that it's individualized and it's not given acutely. You want to wait a while for it, but it's not an absolute contraindication. And that's just what I want to bring out. But yeah.
Yeah, fantastic. Great. Thank you so much. I think with regards to the statin, I was taking a little aback. It's good that you brought that up. And then the question on the reperfusion injury, I think the person was talking more about like supplemental oxygen, and like you rightly said about the fact that we don't do a lot of the reperfusion strategies and all of that. But even in that, I think practically, or like talking to what we do in the district hospitals or like at the lower levels, typically we tend to give a lot of oxygen to those who have stroke. I think the guidelines discourage this. If your SpO2 is more than 94, if you look at the American Heart Association or the American Stroke Association guidelines, they will typically recommend like the supplemental oxygen when your SpO2 goes below the 94. And that in itself helps as well. So we know that excess oxygen can worsen usually oxidative stress, and then that can potentially then increase your reperfusion injury like you was talking about. So the aim is usually to maintain the oxygen around the 94, 98% thereabout. So it's not routine that everybody who has a stroke without evidence of some hypoxemic state, you just go about giving like oxygen to all of them, really. Then, of course, that comes in the other one regards the reperfusion and all that comes with it, especially the need to avoid the hypoxia or hyperoxia during the reperfusion therapy. I'm sure Dr. Atto, I think he spoke about that as well. So if the person is not, if you want to probably highlight more on it, if you are happy with what we have said as well, that's fine. Otherwise, you can come back again and then we'll. There are two other questions. Can you guys now see them in the chat box, or am I the only one seeing it? So there's one from, I think we've answered the first one.
Yeah, I've seen.
And
I've
great.
seen Ajimambedu. So he
Exactly. Yeah. Great.
Okay.
Take it.
Thank you so much for this in-depth presentation. Could you kindly clarify as to when exactly to adopt dual antiplatelet therapy in ischemic stroke? Knowing some studies have suggested there's no benefit in using them in the long term, but rather have adverse effects. Okay, hemorrhagic transformation. Thank you. So, like Dr. Ologo mentioned, we don't do dual antiplatelets routinely for everybody. With the dual antiplatelets, what we do is once you evaluate the patient, you need to calculate their NIHSS score. Now, you are right. The NIHSS score usually is what guides us whether we do dual or not. So, normally, when it's less than 5, so anything below 4, we tend to do double antiplatelets. That means that it's a mild stroke. And if the stroke is very severe and you do dual antiplatelet, then that's when it puts them at an increased risk of hemorrhagic transformation. However, even for those that we do the dual antiplatelets, you don't do both antiplatelet medications long term. You usually do both of them for 21 days, then we drop one, then continue on just one. So that is all in relation to reducing the hemorrhagic transformation risk. And of course, for every patient, like I said, you have to individualize the care and risk stratify them. But generally, as a rule of thumb, we only do it now for those with NIHSS score of below 5. I don't know if that answers it, or if Dr. Akatiba would like to add on to it.
Yeah, I think I'm perfect with it as well. Thanks.
All right. Then there's another one. Thanks for the presentation. I'm worried about the treatment without a confirmed image. CT scan to be precise, especially when I'm not sure of the type of stroke. Yeah, so we've been talking about this for a very long time now. And Dr. Katiba himself, I remember back then would always say that once you have not confirmed, don't say because the BP is high, it's likely to be hemorrhagic stroke. Then you are doing your own thing somewhere. Unfortunately, with the new guidelines and protocols, you need to have imaging evidence before you go ahead and treat. And that is one of the main challenges we face where we practice, because those of us in rural Ghana, in the Upper West region, for instance, we have just one CT scan that is serving the whole region. So you can imagine the constraints. So that's a challenge. But the treatment is you have to confirm it first. People have come referred from other facilities as infarctive strokes because they will say, oh, this was this, using clinical. We will do the CT scan and it's hemorrhagic. And patient is on double antiplatelets, atorvastatin, everything. And we now have to hold it. So unfortunately, you need imaging evidence before you go ahead and start your double antiplatelets or whatever. But if you are constrained, at least you can try and manage the risk factors and refer to a facility that can do the imaging if they are very ill. So I don't know if that sorts out. So that should do. Someone wants us to unmute him for him to ask something. I don't, Dr. Akatiba, I don't know if you are there.
Yeah, if you can kindly just put up your hand and then I can unmute you, the one who wants to talk. Dr. Ato,
Okay.
is that the last question?
No, thank you, Dr. Henrietta. How is migraine a risk factor for stroke? I thought it's a symptom. So that is an interesting question and a comment. So it's studies that have shown that people with, and it's not just migraines, it's migraines with aura, especially in women. And you know, the study that actually came up with that, the risk was not increased in men with migraine, unfortunately, or fortunately. It was more with women with migraines, and not just migraines, migraine with aura. And they tend to find an increased risk of stroke in such patients. And it's got to do with the underlying pathophysiology of migraines. Technically, migraine in itself, we don't even understand everything fully about migraines, but migraine has a tendency to affect the vessels and cause endothelial injury. So that is where they act as a risk factor for stroke. So yes, you are right, but unfortunately, because of the migraine is also a vascular problem, and anything vascular, once it can cause endothelial damage, it will lead to the formation of inflammatory cells and things coming into that space. Over time, can lead to an occlusion of that vessel and can reduce perfusion to the brain. So that is how it plays its role. So I hope that answers your question or your concern. So someone says, I have a question. Can masturbation lead to stroke in young or aged people as well? So it's similar to a question I was asked recently when someone asked, can sex cause stroke? So it's not, I must say that it's not the process itself directly causing it, but it's more of an indirect cause. You cannot, I haven't seen in any literature that says masturbation directly causes stroke or is a risk factor for stroke. But I think what happens is it's related to the cervical cerebral artery dissection she spoke about. Now, in young people um, who who have or who are engaged in sports or even high acceleration, deceleration, velocity injuries, sometimes it leads to damage to their cervical, cerebral, sometimes they say cervical cranial vessels, and it causes dissection. And that dissection that it causes within the vessels can be a risk factor for stroke. So maybe if I look at it in that direction, yes, but it's not a direct causal relationship between masturbation and stroke. I haven't seen it anywhere. I don't know if my boss has seen it anywhere. Maybe he can speak on that as well. Or if Ologo saw it in a reading. Dr. Ologo, did you see masturbation causing stroke in young people when you're reading?
No, not causing, as you said, it just like potentiates if you already have other risk factors, it increases your risk. because but like not a direct cause or risk factor. No.
Okay, so can patients be anticoagulated whilst they are on double antiplatelets? Certainly, certainly. In patients, we anticoagulate patients who are on double antiplatelets all the time, but it's not therapeutic. Most of the time is prophylactic. But for patients who may require therapeutic doses of anticoagulation while they are on double antiplatelets, may have additional cardioembolic risk or comorbid conditions like atrial fibrillation and other things. So if you are talking about stroke and the stroke is a cardioembolic cause, maybe the patient has some AFib somewhere, of course, then and the NIH score is less than 5, of course, then that patient will be on anticoagulation and at the same time on antiplatelets. But in all of these patients, I must say that this must be done under the guidance of a specialist or at a facility where you have specialists, because you need to closely monitor their bleeding risk. And of course, with patients with on anticoagulation and double antiplatelets, you always have to, especially if it's a cardioembolic cause like atrial fibrillation, then you have to calculate their SHAD-VASc and their ASBLED score, because you have to balance their risk of anticoagulation, their need for anticoagulation against the risk of bleeding. So yes, to put it bluntly, yes, but it must be individualized and patients must be closely monitored for bleeding. All right. Do we still use TIA? I've come across a statement that stroke is irrespective of the duration of the signs and symptoms. Yeah, so I think what you mean is in the past, we say that if your symptoms are less than 24 hours, then it's TIA. If it's more than 24 hours, then it's stroke. Yes, we don't use that 24-hour cutoff anymore. We don't do that anymore. So I guess that's what you want to say. But TIA is still a recognized term, except that period less than 24 hours has been taken away, but transient ischemic attack is still very well recognized. It's just that right now it's irrespective of the duration. So the key thing between your TIA and your stroke is actually imaging evidence of the infarct or of the infarct on your CT or MRI. And I think I would just want to add as well, in the presentation, she mentioned that MRI is a gold standard, which is true. But when they come in acutely, you have the chance to do a CT. That's the initial investigation. Once you rule out a bleed, it gives you the chance to be able to thrombolize, which is a form of reperfusion. And she spoke about it in more details earlier. Dr. Katiba, please, how many more questions can we take?
I think we can do 2 more and then we take it.
Please,
There was Oko who, is that Oko?
Good afternoon.
Hello? Yes, please go ahead. Yes, please go ahead.
Yes. Please, I have 2 questions. So one question is specifically on the oral contraceptive pills, because we have types of contraception, which is the implant and then the injectables, but it seems it is being stressed on the oral contraceptive, which is she said migraine, and the oral contraceptive, we have them combined and then the microlux. So which one are we talking about? And my second question too is relating to the stroke in pregnancy. So when a client, let's assume that the client was on my combined pill for a long term, like 2 years, and then she stopped to pick a seed or to get pregnant. After pregnancy, that is a postpartum pepper side. As Doc rightfully said, is this client at risk of having a stroke?
Okay, that's a very good question. I'm glad you brought it up. Sometimes you get that. So with the contraceptives, is the studies that were done is the combined oral contraceptives, estrogen and progesterone containing OCPs. They are the ones that demonstrated. The paper documented, I think, 1.7 to 6 times relative risk of stroke compared to the women that were not on the contraception. So it was a combined. So yeah, even though we are talking about contraceptive, it wasn't with regards to all forms of contraception. It was the combined oral contraceptive pills. So they had about 1.7 to 6 times relative increased risk of stroke compared to the women. And what they also found in that study was that the risk was increased with higher doses of estrogen. And it even demonstrated to show about a 2-fold increase for women who were taking the estrogen doses that were more than 50 micrograms. So that is it for the first part. The second part, you said if the woman was on contraception and she stopped for 2 years, and is that what you said, 2 years?
Yes, sir. I'm saying that if like she was on that contraception for long term, greater than 2 years or within 2 years, and now she stopped to pick acid or to get pregnant after delivery, is she at risk of having this stroke or suffering from the things that we are talking about? Thank you.
Okay, so it's a very good question. Thank you. The 2 years is enough period to cause some form of washout. But I would hesitate to not stick out my neck and say she's not, because pregnancy in itself is a prothrombotic state, which increases your risk of stroke as a woman. Pregnancy in itself. So yes, you may be after 2 years of stoppage, risk is definitely going to reduce if it's solely based on the oral contraceptive pill. But then remember that we also mentioned that pregnancy in itself, even though it's rare, it's also a risk factor for stroke, and the risk is actually highest in the third trimester throughout the first 12 weeks postpartum. So the postpartum period, what do you call it, correlates with an increased hypercoagulable state. And if you look at the various pathophysiological mechanisms that have been attributed to that, it includes like risk, what do you call it, eclampsia, those who have added risk, eclampsia, those who have cardiomyopathies in pregnancy, amniotic fluid embolism, cerebral venous sinus thrombosis, and the likes. So it's there, but the risk from the oral contraceptive itself may be reduced if she's been off it for 2 years. But then, just by virtue of the fact that she is pregnant, still puts her at some risk, even though it's rare. We've what do you call it, managed stroke in pregnancy several times, and just last month we had a patient like that at the maternity that had delivered, if she even had CS, and still developed a stroke postpartum. So women, you are special, but there are also some peculiarities to just by being a woman, and it's all related to the hormonal issues. I don't know if that answers your question.
Okay, sir. Thank you, sir. God bless. I'm okay.
You're welcome. You're welcome. Thank you for the
Thank
question.
you.
Yeah. Dr. Famselom. Oh, Famselom, how is it? Clopidogrel is a prodrug. Its benefit is derived from the activated form, acidic medium. As such, drugs that have the potential to raise stomach pH must be taken into consideration. Okay, thank you very much for that comment, Famselom. So I guess we've answered all the questions. I don't see okay, there's another one here. Oh no, I think we've answered everything. I don't know if there are any further questions. Over to you, Dr. Akatiba.
Yes, Dr. Atto, thanks. I think you've done the justice to all of them, and there's no other question. Actually, we've gone way beyond the hour mark, but I'm sure it's all for the good. And so, thank you so much. Thank you, Dr. Henrietta. Thank you, everybody, for joining us for today's presentation. If you check in the chat box with me, I've just put up how to assess the webinar recording. You realize that this has been recorded, so we'll put it up on the Ghana Medical Help YouTube channel. I've put the link in there. You can have that. You can have the slides when you get onto that site as well. So you can click and subscribe to that channel as well. If you want to join us on WhatsApp, I've put the link there so that all our presentations, you get to know about them, what topic it is, and what you would want to. And then I've put up our Facebook page as well, if you want to like that one, and then our LinkedIn account. So on social media, I'll put all of those ones up as well for those who may be interested in following us on our various projects, our webinars, our training programs, our donations, and our impact stories. So I think that is it. Lots of midwives joined us, so I was really happy we brought up the issue about the OCPs. Don't be afraid about them. You just need to do the appropriate thing. The risk of stroke is there. And like Dr. Atto mentioned, I think the most recent one has been the 2025 European Stroke Organization study, which looked at the combined OCPs, like you said, and that was around a 3 times increased risk. But just like we always mention, these are risk factors and not direct causation. You just need to adjust for other factors like the age, the smoking, hypertension, and then the migraine with aura, especially, and obesity. And these are really usually things that, in association with the combined oral contraceptive pills, may cause some issues. But don't be afraid; just do the right thing. In our country, we don't routinely do the factor 5 laden, which I think is one of the key things that we should have been doing. But of course, third world problems. Otherwise, typically that with OCPs as well will usually cause a lot of prothrombotic issues. So thank you so much for joining us. Thank you, Dr. Ato. Thank you, Dr. Olo. Henrietta, did I get the surname right? It's Ologo?
Ologo.
Yes, please.
Okay,
Ologo.
thank you for an excellent presentation. I've learned a lot. I'm sure most of our participants have learned a thing or two. We had on the average 150 participants, went up to around 160 and about 134. So really quite a good number of people. So next week we would have another presentation, and kindly follow our social media channels. It will be advertised there. Thank you so much. Have a blessed day and God bless all of us. Bye-bye.
Bye.